Good morning, Chicago. I'm Dr. Allison Arwady, Commissioner at the Chicago Department of Public Health. Today is Tuesday, February 22nd, 2022, 2222. And I thank you for joining us. As always, this is your chance to get your COVID questions answered. As you see, we have a special guest today. This is Dr. Erica Taylor. She's one of the medical directors at the Chicago Department of Public Health. Welcome.
Thank you so much for having me.
Of course. Can you let folks know just a little bit about your background, both a little bit of what you were doing before coming to CDPH and then what you've been working on since you've been here, so they know what kind of questions to ask?
Absolutely. So I'm a board-certified obstetrician and gynecologist. Prior to joining Chicago Department of Public Health, I worked as the Associate Program Director for the residency program at Mercy Hospital. I also worked for a number of years as a generalist, so I delivered babies and also did surgery, took care of women for the entire spectrum of their life.
Great.
I made the transition over into public health in October when I joined here.
Yep.
Currently the medical director for congregate settings, where I'm tasked with basically taking care of some of the most vulnerable populations that we have here in the city, which includes homeless shelters, correctional facilities, and also have seniors, youth, and assisted living facilities.
Excellent. So lots going on here. So if you've got questions, especially about those higher risk settings, but also just about COVID in general, obviously, the OBGYN portion of it, Dr. Taylor and I will both take your questions. So as always, you can put your COVID questions directly into the box below. You can also use the hashtag AskDrArwady on either Facebook or Twitter. So as always, let's start with our Chicago data, chi.gov/COVID-. And if we pull it up here, we see really very, very beautiful progress. I'm really happy with this. You can see we're averaging 283 cases per day, down 37% from a week ago. 27 hospitalizations, that's new hospitalizations of Chicago residents with COVID every day, down 29% from a week ago and down to 1 per 100,000 per day, which is good. We're back down to 4 to 5 deaths, down from 9 to 10 a week ago. We're doing about 4,000 new vaccinations a day, about 25,000 tests a day, and because our testing still remains quite high while our cases remain low, our positivity is at 1.5%, which is great. I want to just show you here, we've gotten some questions about being able to look at the community transmission and risk here. And so if you click there, you can see where we are today. And so you can see our cases are now in that substantial transmission category, down from high last week. We've seen our test positivity move all the way down to really that low, controlled, under 2%, which is great. And then just as of yesterday, we've seen our 7-day average for hospital beds, non-ICU, come down into this lower transmission, which is great. And then ICU also be in this lower transmission for a few days now. So 3 of those 4 have hit the metric of being in lower or low transmission. We will be having a press conference at 2 o'clock this afternoon to talk about what this means and timing, but obviously it's very good news for Chicago. I also wanted to show you up under latest data where you can see some of the information. If you want to see about breakthroughs, for example, if you click here, there are some graphs and data that help you look at, in Chicago specifically, every week we're updating. Red shows cases in people who are unvaccinated. The light blue is people who are vaccinated but not boosted, and then the dark blue is people who are boosted. And so if you want to take a look at cases, hospitalizations, deaths, you really see that difference. You can also look at it by age. We're now updating just over the past 4 weeks. So you can see, for example, over the last 4 weeks, just in Chicago, unvaccinated Chicagoans in red here, since just late January, have had about a 13 times higher risk of dying from COVID compared to Chicagoans who are boosted. And you can see the actual data and download it. And then some of you were asking about age groups. So you can also come here. There's a lot on there. So I would recommend just choosing, for example, like if we look at, 50 to 64-year-olds. Similarly here, this is for cases. So the dark blue are unvaccinated 50 to 64-year-olds, and then the dotted are fully vaccinated or boosted. And no matter whether you're looking at cases, hospitalizations, deaths, you can add different age groups. And I think, I don't know if you have thoughts, Dr. Taylor, here. For me, like when I'm looking at, for example, these like let's say the 30 to 49-year-olds, for example, not very likely to be hospitalized compared to the older folks, but still a big difference there in terms of the risk that folks are having if they're vaccinated versus unvaccinated. Anything you want to add to that?
I think also when we're looking at the different age groups, also thinking about some of what the underlying conditions that we have as we age. So things like hypertension and diabetes can be underlying as well.
Exactly. And so if you look at 65 to 79-year-olds here, much more likely to be hospitalized. But this lets you sort of change out, look at the different groups and explore that further for each of those. So that's a newer feature on the dashboard that some of you were asking for. And then just to remind you, up here is also where you can see what's happening with variants, wastewater surveillance, hospital capacity, doubling time. You can get the coronavirus at a glance. All of that is up here in addition to our standard dashboard. So let me pull up just a couple of slides. We already looked at the risk matrix. We've gotten a few questions. There's been a lot of actually new science out the last few days or last few weeks. And some of you were asking about things like what are we seeing in terms of whether boosters are actually making a difference in terms of protecting people. And so I just pulled one example here. We did a little bit of science. This is a brand new preprint. The link's at the bottom. But basically what this is showing is on the left here. Do you see where it says in purple, Wuhan WHO, and then Beta, and then Delta, and then Omicron? This is how much the antibodies are neutralizing or sort of fighting the virus. So you want higher. On the y-axis here, we see neutralizing activity, higher is better. And so what you see is against the original version of the COVID virus, after 2 vaccinations, your antibody levels are here, 1.3 months after and 5 months after. So we do see some of that fall off. I know some of you are writing in saying, I hear that we lose some antibody protection, which we do as time goes on. So you can see in green here, that's after the second dose. We always see a little bit of that fall. But then with that third dose, with that booster dose, really a very nice increase, and in fact higher than where you started because your body's had more opportunity to sort of learn. There's been more time that's passed. And so we really did see a very nice increase, no matter which of the variants you're looking at with that third dose, and even higher than where we'd started. Now we do expect this antibodies to wane, to drop a little bit as time goes on, and that's where some of the conversation is. Some of you have been writing in and asking, when might we need another booster? I don't anticipate, in the absence of another, big problem with a new variant or some major surprise, I don't anticipate we'll be talking other boosters, for months at a minimum, I would say, probably till the fall or the winter. We'll see what happens a little bit. But even then, it may be something more for older people or people with underlying conditions. So that's really good news, a brand new study. And then the other study I just wanted to bring are 2 different studies that were both published in Nature in the last couple of weeks. Nature is one of the very, very top science journals in the whole country and the whole world, really. And so there's a lot on here, but let me just kind of talk you through them, and then you can read them yourself if you want. So it's not just about antibodies when we talk about protecting people after getting a COVID vaccine. So the antibodies are important. They're the first line of defense. But we saw during Omicron in particular that this antibody neutralization means killing the virus, fighting it off, not letting it get in. We saw that the spike protein had quite a lot of mutations in it in Omicron, and that meant that the antibodies were not always quite as effective, and so we didn't see as much vaccine protection from infection. But we did see excellent protection from severe outcomes, like we were just showing you in the dashboard there. So even though we saw a lot of breakthrough infections, we didn't see a lot of hospitalizations or deaths. And so that's where the scientists have been looking to say it's not all just about antibodies, it's about the other parts of the immune system. So there's T cells, there's B cells. B cells are what sort of make new antibodies over time. But there was good news out of this study on the top here by Keaton and others that basically looked at the T cells in the Omicron in people both after vaccination and after recovery, because people write in about that a lot too, who had not had vaccination. And they saw that about 70 to 80% of the T cell activity gets maintained, even though Omicron had many more mutations. So what does that mean? That means that even if the antibodies, people don't have as much of that immediate protection, the T cells come in just a little later, and it's a different way of sort of fighting it off. It's a lot harder to measure T cells than it is antibodies. Antibodies you can just check in blood. T cells take a lot more intensive lab work. But this is good news that we still saw about 70 to 80% of that T cell, that longer term protection being maintained. And then this second study, also in Nature, was pointing out that severe disease, again, is pretty uncommon in Omicron. Luckily for people with both naturally acquired or vaccine-induced immunity. And again, that's highlighting that there are these other parts, this adaptive immune system, like the T cells, not just the antibodies. And so in this case, we don't have to get into the science, but there are two different kinds of T cells that can find the spikes of COVID, so CD4s and CD8s. And they were able to see, again, you want a higher level of sort of protection or recognition for Omicron. And in people who were previously infected but not vaccinated, we saw about an 84% sort of recognition of Omicron. Higher is better. And in people who were vaccinated, about 91%. So little better in vaccinated, but quite good in both. For the CD8, which is another kind, for people who had previously been infected, we saw about a 70% cross recognition, so showing that coverage. And in those who were vaccinated, about a 92%. So again, suggesting, you know, we've been saying all along, the combination of being both infected and recovered and being vaccinated is the best protection out there. Next would be vaccinated, next would be previously infected, and we worry the most about folks who have not had neither. So the last piece of data wanted to just show is how we're doing in terms of vaccination by race and ethnicity. So at this point, 61% of Black non-Latinx Chicagoans have had a first dose of vaccine, which is great. That's good progress. For a long time, we were trying to get over 50, really happy to get over 60, 54% fully vaxxed. But that is behind still what we're seeing for the other race and ethnicity groups. So you can see really an important benchmark this week where Latinx Chicagoans are now just as likely to have gotten one dose of COVID vaccine as white Chicagoans are. You can see in blue and red, both at 75%. And then Asian non-Latinx are at about 84% in terms of that first dose. There are a lot of Latinx children in Chicago, especially young children, and this is all ages. It would include the children who are not yet eligible. So I actually expect that we'll probably see Latinx coverage pass white non-Latinx coverage as we keep getting kids vaccinated and as the younger ones do. And so I just wanted to highlight here that, you know, it's been good to see this improvement, certainly in the Latinx and coverage coming up to match it. But one of our biggest concerns still is this difference, especially with some lower vaccination rates among Black Chicagoans, and we can talk about that in a minute. Want to remind you, we have plenty of appointments available at the family vaccine clinics this weekend. These are doing hundreds each day. We're at Truman on Saturday and Malcolm X on Sunday, 9 to 2. You can register in advance. And our vaccination at home, Protect Chicago at Home, going strong. Seeing lots of people getting adult vaccines, pediatric vaccines, booster vaccines. We've got appointments 7 days a week into the evening, and we would like nothing better than to come give you a vaccine. Remind you that if you test positive for COVID-19, no matter whether you are vaccinated or not, if you have underlying conditions, if you're over 65, we want you to call your doctor as soon as you test positive, even if it's just a home test, because there are these newer IV and oral medications that can help keep you out of the hospital, but you have to take them in the first few days of infection. They stop the virus from copying so much, for example. And so these are provided by the federal government, no cost, no insurance required. They are available in Chicago, but it's too late if you get infected and you think you'll be okay, and then a week or two later you start to have some trouble. So please, we say this every week, but a reminder to call your doctor. Give us a call if you're not sure, if you don't have a doctor and you need help getting connected. And as always, 312-746-4835 is where you should call. So let me get out of this. Perfect. So So Dr. Taylor, maybe let's start actually with a little bit of conversation about the lower rate in Black Chicagoans, because I know that's something, certainly you are concerned about, but also you've been thinking about, are there different things we could be doing? Are there new ways we could approach it? You want to talk just a little bit about your thoughts there, what you've seen?
Sure. Absolutely. So I definitely think this is an area in which we need to have more outreach in regards to really meeting individuals, I think, where they are. I think we have to kind of get past the megaphone approach and really try to meet people on a base level, as far as let's have a conversation about why you're not vaccinated and really try to understand some of the underlying reasons. There's a lot of historical ramifications that have, basically prohibited people has led them to have COVID vaccine hesitancy. I think really trying to talk about some of the myths, and so really dispelling that. But I think it's also important that the individuals also see trusted messengers that look like them, that are relaying the information. I think that's also huge.
Yeah, absolutely. Yeah, I couldn't agree more. This is why, as the numbers have come back down, we're not needing as much of the contact tracing, et cetera. And so we do have some of the vaccine ambassadors out again, in some of our less vaccinated communities, doing that outreach, doing that door to door. But I think it's also about, providers that look like the community, having those conversations. Are there things that you've seen in other places, or other, kind of other thoughts around that you might have?
Well, I think sometimes in reaching, let's say, some of the younger population, I think really utilizing some of the key maybe influencers. And so having some of those individuals maybe creating a TikTok, or maybe creating these alliances with groups that can actually reach those individuals who are highly unvaccinated.
Yeah. Absolutely. And can you talk a little bit about what you've heard, whether it's myths or confidence, et cetera, particularly for pregnant women, given your background there around vaccination, or anything you want to share there? Because we definitely get lots of questions about that.
Sure, absolutely. So just in regards to some of the myths around pregnancy or fertility, there is some thought that women should not take it when they're pregnant. There's this myth that it can lead to a miscarriage and things of that nature. However, one thing that we have to think about is that when a woman is pregnant, she's able to basically pass on antibodies or protection to her unborn child.
Yep, just like those antibodies we were showing you in that study there. Yeah.
Correct. And so an infant does not develop their own immune system for 6 months. And so by a mom being vaccinated, she is protecting her child. Yep. And so really that's one of the key reasons. And so the other thing is that women that basically are infected with COVID-19 are more likely to have severe outcomes, more likely to be hospitalized or be intubated, needing a tube down their throat to help them breathe. Yep. So pregnancy is thought to be a condition in which our immune systems don't work as well. And so that's the reason why their systems are being attacked much more heavily than someone who's non-pregnant.
And that's because, you need to not be rejecting the baby that's growing inside, right? And so you see these changes in sort of the immune system, but it can mean that women who are pregnant sometimes can get sicker than they would otherwise.
Absolutely.
Okay? Yeah. Okay. All right. Let's get into some questions here. Okay, lots of comments. So let's start with, oh boy, lots of comments. So let's start with maybe Daniel Lopez on Twitter. He says, how is positivity rate being measured correctly? With at-home testing now the norm, reported results are undoubtedly skewed. Yeah, so there's a few things that go into this, and you should definitely chime in too. So one is that we are doing, the tests that are in here do not include at-home tests, but we actually are testing dramatically more than we were previously. So if you go and look at that dashboard, if you hover over the lines, you can see what the numbers were. Last summer, the last time we were in a place where things were relatively calm, we were doing about 7,000 or 8,000 tests across the whole city every day, meaning formal tests in laboratories. Even now, we're doing, when things have calmed a lot, we're doing about 25,000, 26,000 a day on average. And so we're doing 3 and 4 times what we were in laboratory settings first. And then secondly, on top of that, we've had so much more access to the at-home tests. I love the at-home tests. I think the at-home tests, I took one this morning. I have a little bit of a cold because I saw my nieces and nephews, and they don't have COVID, but they had a cold. I had, feeling a little stuffed up. The ability to sort of take those tests regularly. But there's a lot of bias in reporting those because if they're negative, people don't do anything about them typically. If they're positive, in many cases they're calling their doctor to report it, but in many cases they're not. They're just doing it themselves as well. So we know that, I mean, we have never counted every case, if you know what I mean, like ever since the beginning, because there wasn't a lot of testing at the very beginning, and then as things have moved on. We use something called an ascertainment bias, if you really want to know the epi term, that says, what is the bias in terms of, are you ascertaining, are you finding all of the cases or not? And so across the country, generally scientists will say your ascertainment bias is going to be somewhere in the 3 to 5 range, and that includes your at-home vaccinations, meaning that there are probably about somewhere between 3 and 5 times the number of actual cases as what is being formally reported, between the combination of what we're seeing in people who are doing at-home tests versus just people who are asymptomatic and don't know it. And so in a place like Chicago, where we actually have very high testing, we're doing a lot of testing, we have a very low positivity, that's where that positivity under 2%, but even under 5% is considered good, we would say we probably had an ascertainment bias of more like 3. So that gets relevant as we start thinking about what is the risk when you're out and about, et cetera. So epidemiologists are always making some assumptions, of course, but we do work into those, you know, and as we use our metrics, we actually, in the case of COVID, we've seen many, many more at-home tests at the same time that we've seen many, many more in laboratory tests. And so in a lot of ways, those actually have balanced each other out. Moving forward, as we come past Omicron and be looking, and really, obviously this is endemic at this point, meaning it's not going to be eradicated. We've been saying that for a year plus. We have to make sure we can detect surges, that we can protect the healthcare capacity. Most of what we'll be looking at are the hospitalizations, the deaths, the severe outcomes, the ICU. We'll also obviously be checking for variants. We'll be really, you know, if you were on with me a couple of weeks ago, we had the epidemiologist who talks about influenza, who does influenza for CDPH on, kind of talking about that. But I think, you know, the results are sort of skewed, if you will, but they're skewed in a way that we can predict across the country. We also know how many at-home tests are being sold. There's a lot behind the scenes that kind of goes into it. Anything you want to add about sort of, you know, testing or positivity rates, things that you're hearing come in?
And one of the other things that's also being looked at is the wastewater.
Yes.
And so how you can actually look at the number of COVID infection based upon wastewater.
Yeah.
And so that's some new information that's coming down the pipeline.
Yeah, absolutely. And in the correctional settings especially, they've been using that. Do you want to talk just a little bit about that high level?
Absolutely. So we were actually just looking at, you know, at Cook County Department of Corrections. They're testing the wastewater there. And so we're seeing like there's a trend, like the units in which they're closely concentrated versus like Division 11, which is kind of far away. That was kind of the last place where we saw like the increase in incidence of COVID. Yeah. And so it's definitely relating to the incidence of COVID-19 in the community as well.
That's right. And so where you see some of this wastewater surveillance, you know, you can see, if you go to the website, you can see some of the high level that we have, but there will be these ways of monitoring it that are not about counting every case, which for a disease that's endemic, you don't need to count every case, but you do need to have a good sense of what's going on. So yeah, I love that. Wastewater surveillance, other ways of monitoring people coming into emergency departments, coming into physicians' offices with sort of influenza or COVID-like symptoms and what we do with them. Okay. Monica Ang on Facebook. How is the possible rise of BA2 working into the city's reopening plan? So BA2, you know, there's 3 different subvariants at least of Omicron. One of them is this BA2. We've had it here in Chicago for weeks already, and we've not seen a major impact on our data, which is good. Obviously, we continue to monitor for it, but no matter what variant we're seeing, the way we make decisions is how that actually shows up in the population. So what is it doing to cases? What is it doing to especially hospitalizations, deaths, emergency department visits, et cetera? And so really risk overall is risk regardless of what variant you're seeing. Of course, you know, BA2 does seem to be a little more infectious potentially, and there are some folks out there that are concerned that if we get to a certain point, maybe we would see a little more trouble with it. But I'm really reassured. One of the reasons I showed a couple of those studies is that as more studies have been coming out just in the last month or two, I'm feeling increasingly reassured about the good protection vaccines give in a long-term way, regardless of the variant. That's sort of the point of some of that I showed, that as opposed to needing to make a new vaccine for every single variant or subvariant, that especially when we're talking the B cells, the T cells, your immune system keeps getting smarter, all the time after you've been vaccinated. And I think it's actually very good news for continued protection for vaccine. Okay, Face State on Facebook. What is the situation with the Omicron variant? So the Omicron variant continues to be more than 99% of what we're seeing. It's very contagious, so it is outcompeting the other variants. And so what you are seeing right now is virtually all Omicron variant. Okay. So Adair Small, this is a good question. You could start with this one if you want, and then I'll chime in. Adair Small from Facebook. How does the current data translate into individual risk on the street? Quote, leaving your pod, going to the grocery store, mixing with random strangers. You want to sort of start with that? If people are asking you that, how you help them think about it, and then I'll put a little bit of numbers on it.
Okay, so I guess I would just first start by saying that I would basically continue to use the preventive measures that we have in place as far as like still maintaining that 6 foot of distance, continuing to wear a mask. I think that potentially we should just treat each individual that we're coming into contact with as though they are COVID-19 positive as a way of protecting ourselves. I think good hand washing as far as like mitigation is key. I think also like really knowing who the people are that are outside of your pod, like knowing like vaccine status, I think can be important, or knowing if individuals have symptoms, whether it be co-related and things of that nature. I think it's important to kind of just ask individuals if you're going out for, let's say, a dinner. I think it's okay to ask a friend like, oh, are you vaccinated? Or, they should be here in the city of Chicago.
Yeah.
And just really just seeing if they have any symptoms and things like that, just to kind of just protect yourself.
Yeah, absolutely. And I would add to that, that I think, these things, Adair, that you're raising are sort of, I think, when you feel like you don't have as much control, right? So to your point, the higher risk always, from the very beginning of COVID, has been the people, when COVID gets into the people who are closest to you, right? Like the spouses, the children, the people who live in the household, that has always been the place where COVID is most likely to be spread, because that's where we let our guard down, that's where we take our masks off. The general mixing, sort of at the grocery store, out on the street, et cetera, where interactions tend to be much more fleeting, are not usually where we tend to see a lot of COVID transmission. But you can turn the data into risk factors. So this is where, using that ascertainment, that I was talking about, for example, this is where some of the scientists, they make estimates based on, at the county level. Right here, for example, in Chicago and in Cook County, depending on that ascertainment, if you had a group of 50 people randomly selected from across the city at this point, 50 people, you'd have about if you had an ascertainment bias of 3, about a 1 in 5 chance that somebody still in a group of 50 people has COVID and doesn't know it. It's about 21%. So that doesn't mean that you're going to spread it, right? But it does mean somebody in that group of 50 may have it. And so this is where, particularly, I know a lot of people, even as mitigations continue to lift, et cetera, there are people who will continue to wear masks, particularly in less predictable situations, and that's good and it's appropriate. At this kind of level, if you get down to 25 people who are, again, random across the city, you'd be at about 11% chance that somebody in a group of 25 would have COVID. So that risk is dropping by the day, and it's really quite low. So I would really say, when we're at a point to be able to lift some of those mitigations, like the mask requirement for public indoor settings, it's because the risk truly is lower. So I think that's helpful. Okay. So, comment here, Anastasia Lindsay Rogers says, why did you tell activists there are no this is not COVID related, there are no slaughterhouses in the city of Chicago when you're aware of the 13 here? Do you have plans to address the public health risk? So, this is related to, as I was on my way over to Facebook, there were some folks who were wanting to talk to me about some butcher shops. So as you know, Chicago has a long history of slaughterhouses and meat packing. None of those are still operating in Chicago. We do have around a dozen, 12 or 13 butcher shops that will really, for religious reasons, halal, sell somebody a freshly killed chicken. And the health department inspects those only from the food safety perspective, just like we do every restaurant anywhere that's selling food. I do not see a public health risk related to this. And CDPH in particular, we are not involved in investigating, animals, et cetera. That is the Illinois Department of Agriculture. So I do not have a major concern about the 13 individual butcher shops here in Chicago. All right. Mary Rodriguez on Facebook. What are your thoughts on California's COVID endemic plan, shifting away from crisis mode to navigable risk planning? Is this something Illinois is planning on doing? I'm wondering how this might affect insurance agencies. Interesting question. Trying to deny coverage of tests or treatment with emergency use authorization. Do you have thoughts about that?
I really think that, long term there will be a need to shift to like more of an endemic plan, just because we have to figure out how to coexist with COVID, I think.
Yeah.
And I think that the fact that the metrics are trending downward and continue to trend downward, that definitely gives us reassurance that we can move from a pandemic mind state to more of an endemic mind state, and really looking at, some of the, maybe some of the underlying, chronic conditions, looking at more optimal health outcomes and things of that nature. I think that would be key. Yeah,
exactly. I mean, we don't talk about that as much, but all the work of, exercise and eating well and making sure where folks do have higher blood pressure, et cetera, in control. All of that, in turn, makes you less likely to, or better able to fight off infections when they do happen. So,
absolutely.
For sure. I would say, we already sort of have our endemic plan, if you know what I mean. This is where we're shifting what we're following, like we were talking about with the prior questioner. The insurance question is a really interesting one, I think. We have really seen in COVID an expectation in this country that the government should provide testing, should provide treatment, sort of more of a true public health model of doing that. That is not the way our health system typically works. I mean, how often is it that we can say, we guarantee to you this vaccine is completely free, regardless of your insurance, your immigration, et cetera. That is not typical.
No, it's not.
And personally, I think we've seen some of the value of recognizing that, particularly where there are these preventive things that help keep everybody safe. Vaccines are one of the safest things, safest interventions, but also they help protect others. What do we do to get out of, how do we make sure that these kind of public health protections are widely available, even separate from the type of insurance somebody may have, whether they're working or not. So we'll see. I think the emergency use authorization, I'm not that worried about that part, because pretty much everything that has emergency use authorization is going to get the full approval. We've already seen that happen with the adult vaccines for both Moderna and Pfizer. We've seen a few of the medications already have the full approval. And as time goes on, the data has been very good. And so it's not that the medications or the tests or the vaccines won't move into the full out of emergency use, but I do think we could see some pushback around coverage of them potentially, depending what that looks like. But everybody, there's no point at which an insurance company is not going to cover vaccination fully, because the risk is so much higher for folks who have not gotten investigated. Okay. Ghost Town Chirac on Twitter. Why is it okay for men to walk around with a full lumberjack beard and a mask? That is okay, but firemen are supposed to be clean shaven. So I'll start with that. So firemen or firefighters, the reason the clean shaven there is because that they are providing medical care. This would be the EMS folks who are transporting people in ambulances, providing, helping intubate people in the field, providing that hands-on care. They are wearing an N95 mask. N95 mask, remember, those are the ones for healthcare workers that are primarily for healthcare workers that have the tight seal to your face. Those are the ones that wrap around your head instead of around your ears. And in healthcare settings, we get what's called fit tested, meaning they actually check to make sure that it's a very good tight fit. And so for someone in a healthcare setting, they would be using that N95. Other than that, outside of the healthcare setting, we would not really require people to not be wearing the beards, but it points to the fact that it's all about fit. When the fit is better, the mask protects more, no matter what kind of mask it is. Anything you want to add to that? Is kind of a funny question.
No, I would agree with that.
Yeah. One American from Twitter, does the vaccine provide any increased protection against long COVID? Any thoughts on that? I've got some.
Well, I think that personally, being vaccinated will protect you, whether it be more of an acute version of COVID or long COVID symptoms. And so I think it's key just to really just encourage individuals to get vaccinated, because if we think about the alternative hospitalizations and deaths and things of that nature.
Yeah, I agree. I think, one of the things we're still learning a lot about long COVID. There have also been some, newer studies about that, and we can talk about those next time. But I think number one, the vaccine's your best protection out there against getting COVID at all, right? Like, I still have not had COVID. My vaccine, my booster continue to work well. I may still get a breakthrough at some point, but the protection that I've had, because I haven't had COVID, I by definition can't have long COVID, right? So first of all, it just protects you. But also, I think some of the things that scientists are still studying is that, like, some of those studies that I was showing you suggest that over time, your body gets better. It learns more how to sort of fight off COVID. The antibody levels are even higher. The T cells learn better. The B cells that kind of keep training the little germinal centers to make more antibodies kind of learn how to make them better. And so my feeling would be, with vaccination, you would better be able to sort of fight off, a repeat COVID infection, even if you didn't fight off that first one. You might be able to come in with the T cells a little later, and even if you can't protect against infection, you can protect against some of those more severe outcomes. So, my feeling would be you would probably see you would definitely see increased protection against just getting COVID, which by definition, long COVID. But I would think also, just in the way that it's training your immune system without making you sick, you would probably have some protection against long COVID. But it's a good question. It's one of the things I think we'll keep learning. Brock Warner on Facebook. As other major countries ditch many COVID restrictions, including Australia, which had very strict travel requirements, when can we stop our travel restrictions? So first, as a reminder, the travel advisory in Chicago only applies to people who are unvaccinated. So if you are vaccinated, there is no travel advisory of any kind. And also children under 5 are exempt as long as they're traveling with adults who are unvaccinated. But our advisory, it's not an order, but our advisory does stand in terms of just recommending against travel for people who are unvaccinated to places that have higher risk settings. So I don't see countries entirely stopping restrictions, honestly. You have to test to get into the US, for example. You have to test to get into most other countries. And this, as other major countries ditch most COVID restrictions, I think it's actually pretty variable when you look at that. The ones that are really dropping stuff tend to have very high vaccination rates, much higher than the US does. So we'll see, but it's very hard to travel. It's hard to travel internationally right now to many countries unless you're vaccinated, and I don't see that going away. Do you have thoughts or any? Is that your opinion too, or?
I would agree with that.
Yeah, I think we'll see. Let's take this one. Jesse Barrera from Facebook. Is the virus going to end in April?
Well, I don't think it'll end in April. I think this is something that we're going to be living with. So when we talk about it being endemic, you can think of something like the flu or influenza as an endemic condition or virus that we have here in the United States or in the world. And so COVID will be similar to that. And so I don't think it's going anywhere anytime soon, but I think we just have to figure out how we'll deal and coexist with it.
Yeah, the virus is not going to end in April. I mean, that would be lovely, but I see no reason to think there's nothing in the history of COVID that suggests that this will be gone. Smallpox is about the only one that we've ever actually eradicated, and I think what we will see, endemic does not mean it's gone. It means that it's here with us, and we sort of see increases and we see decreases. If we can keep people, for the most part, out of the hospital, keep them from overwhelming the health system, right? This becomes something where you're not threatening your healthcare system. But I do think over time, the hope is that we won't see another bad variant, that we won't see another big surge. We may start to see more of a seasonal pattern like we do for flu. We just don't know yet. But no, I don't think it's going to end in April. I think the next few months, though, should be reasonably calm, would be my guess. Typically, every 3 months or so, looking around the world, is when we've seen another variant emerge. The world is getting close to 2/3 vaccinated, which is actually really impressive progress. So we're getting there, but it's not going to end. Let's take this. Riz Scully on Facebook says, I haven't quarantined, worn a mask, or gotten a vaccine this whole time. I still have not gotten sick. I haven't been sick in years. Why is that, doctor? Do you want to start with that and then I'll chime in?
Well, I guess I would have to know a little bit more about your underlying health conditions. Are you working in a high-risk environment where you are exposed to individuals that have COVID-19? I think also it can look as far as your overall immune health. So are you someone who, you eat a well-balanced diet, you're getting proper rest, you're exercising? I think that our immune systems play a huge role in regards to us getting sick.
I would also say if you haven't worn a mask this whole time, that suggests to me if you're in Chicago, you haven't gone out. So I don't know if you've been sitting at home perhaps, or maybe you're not in Chicago, but I will say, I'm guessing you're younger based on this, I don't know, but I would be a little, personally, I would be concerned still about not having been vaccinated, given that we have seen even younger people get seriously sick, even with Omicron. And if you've made it this far without getting COVID, that is pretty unusual in the US, honestly. And if you've made it this far without getting COVID and without getting vaccinated, I'm worried about you, because you are in the highest risk category for folks in terms of if you do get sick, potentially seeing those severe outcomes. So I hope that you decide to get a vaccine if you've been lucky enough not to get sick this whole time. Okay, Ann Elliott from Twitter. When will the city of Chicago follow the lead of most civilized locations that understand public health and drop the discriminatory vax passport requirements that disproportionately affect children and people of color? So just to talk about the vaccination requirement for high-risk settings, as a reminder, we did not put this in place last fall when many places did. We thought about it, but things were in reasonable control, and I do believe in people being able to choose whether or not to get vaccinated. However, with the Omicron surge, as we got into January, we started seeing our hospitals and our ICUs filling up. Not just filling up, we had more people hospitalized with COVID-19 in Chicago during the Omicron surge than in any prior COVID-19 surge from the beginning of the pandemic. And you know what? Almost all of those folks were unvaccinated. And so the requirement for vaccination in high-risk settings was because if people have chosen not to get vaccinated when we're seeing 10,000 cases a day, which is where we were peaking, the risk is very, very high, especially in settings where people are taking off masks. And knowing that it's the unvaccinated folks who are ending up in the hospital by and large, that's why we've done it. We don't expect that it will be in place long term. Again, we'll be announcing, we'll be doing a press conference at 2 o'clock, just sharing the details of that. But that was never intended to be a forever thing, but it is something that it did drive a lot of vaccination actually among younger people. But the reason we did it was because of the risk of seeing, we saw a lot of young people getting hospitalized. And I think, if we were to see a surge in the future, we were to see a new variant, a big problem, we're running out of issues, I would much rather have to do masks or a vaccine requirement for high-risk settings than I would having to shut anything down, having to put capacity limits on, other things that are even more of an economic impact. So my hope is that we won't need any of that again, but COVID does keep evolving, and I can't promise that forever. So any other thing you want to add to that?
No, nothing else to add.
Okay. Okay. And some other people writing in, I see Chris Wilder saying, suggesting again, this Omicron BA2 might be more contagious, about to take over the world with a giant horrible surge. What's your view on this? My view on this is that we just don't know. I've been following BA2 very, very closely, and so has my team. We've seen it show up and be the majority of cases in places like South Africa and in Scandinavia with actually really different results. We've not seen it automatically turn into much more into big surges. We haven't seen it turn into a lot more hospitalizations necessarily. We're still learning about it, but we make decisions based on the risk here and the risk of what we're seeing. And so far, BA2 has been here and it has not shown, it has not had a major impact yet. Could it? It could, but we make decisions based on risk that is here now. And I've not seen anything that very clearly says in a setting that is like the US, that it would be a major new concern, but we're keeping our eyes on it. All right, I think we are just about at time. I see a few nice comments there from Kristen Korkowski and PG Beatty on Facebook. Just wanting to say thank you for keeping us informed, appreciate that. Renee Rabiella from Facebook, have you tested the breakthrough percentage on people with natural immunity? Is it because it doesn't fit your narrative? So yeah, that's some of exactly what that data that we were sharing. So on the dashboard, that comparison between people who are unvaccinated, in that red, versus people who are boosted, that is regardless of whether people have previously had COVID or not. We do also look at reinfections, which is what we typically call breakthroughs in people who have had COVID. Do we see reinfections or quote unquote breakthroughs from natural immunity? We do, lots of them. One of the reasons I showed you the results of that study was to say, yeah, you get some protection from natural immunity. Of course you do. Thank God you do, right? Like we'd be in much worse shape if we didn't have any protection. But it is better, it is more predictable, seems to be longer lasting, and seems to do more with T cells and B cells, at least that's what the science is showing, than natural immunity. They work together. The best protected folks out there, I've said this over and over and over again, these were some of the best studies from a year ago, were the ones where they were taking bone marrow and really seeing what was happening. And you saw that folks who had both recovered from COVID and been vaccinated have the very best protection. Next would be people like me, vaccinated and boosted, but I haven't had COVID. Next would be people who had had COVID but not been vaccinated. And then the worst would be people like that person writing in who apparently has not been vaccinated and not had COVID. That person does remain at pretty high risk for not just getting COVID, but potentially having a more severe outcome from it. Anthony on Twitter, where does the city stand on distribution of antiviral drugs? Yeah, that's why I put that slide in highlighting we've got them here. We've worked hard to make sure that they're distributed across the city. Federally qualified health centers have them or can get them through their pharmacy partners. We obviously started with the long-term care facilities, the folks getting cancer treatments and transplants, et cetera. It is all done through the state, IDPH. But we have worked to make sure that there's good availability here in Chicago. The main thing we need is folks calling their doctor so that they can plug in time. All right, so we are just about at time. Anything else that we didn't get to, or that you want to raise, or anything we didn't address?
So I guess just in regards to getting vaccinated, I'd say really just seeking out again good information in regards to the vaccine. And really just making an informed decision, I think, rather than having one that's based on myths. So really, I think just following the science, I think, is going to be key. Mm-hmm. And I think that we can definitely get past this pandemic and get more into this endemic state of mind. Yeah,
I totally agree. So again, this is Dr. Erica Taylor. She's one of our newer medical directors at the Chicago Department of Public Health, has been doing a lot of our COVID work in the highest risk settings, and is an OBGYN by training. So thank you again for being here, Dr. Taylor, and thanks for your questions for both of us. We are doing a press conference at 2 o'clock, and then we will be back on Thursday to answer some more of your questions. I wanted to just also end by acknowledging the death of Dr. Paul Farmer. If those of you had not, he died yesterday, suddenly, unexpectedly, in Rwanda. He was working at a hospital that he'd helped establish there. And yeah, the reaction that you see there is the reaction that the medical and public health community has had. If you don't know who Dr. Paul Farmer was, I strongly encourage you to read about him. There's a book called Mountains Beyond Mountains by Tracy Kidder that came out probably 20 years ago at this point, that is a biography actually of Dr. Farmer and his work. But he had a huge influence on everybody sort of in my, people who care about public health, people who care about global health, people who care about making sure people have the right to access high quality health care regardless of where they live, regardless of their insurance. And he worked in Haiti and Rwanda and a number of other countries. I had the opportunity to meet him just a bit. I didn't know him well, but my Facebook feed is absolutely full of my closest friends and colleagues, all of whom really are saddened by his loss, but are someone who we've really been very inspired by and continue to be. So look up Mountains Beyond Mountains if you want a really good read and an early example of one of the books that made me decide to go into public health and medicine. So, yeah. All right. And with that, we will see you back at 2 o'clock for more of an announcement about how this data fits into what the city will be doing moving forward. Take care, and we'll see you soon.